Hello friends, I am Dr. Deepak Garg. I am consultant orthopedic surgeon and today we will discuss about prevention of venous thromboembolism post orthopedic surgery. So the major orthopedic surgeries which need the thromboembolism prophylaxis are hip replacement surgeries, knee replacement surgeries and the hip fracture surgeries. These will include IT fracture or the neck femur fracture. So either treated by open reduction internal fixation or by closed reduction internal fixation. So all these patients will need prophylaxis. So now let's discuss about why we should give this thromboembolism prophylaxis. So if we will not give this thromboembolism prophylaxis, so approximately 4 to 5% of these patients will develop the thrombus, so which is a life-threatening condition. So we cannot take risk in 4 to 5% of the patients in our routine orthopedic surgeries. So all these patients should receive the venous thromboembolism prophylaxis. So let's first talk about the patients with the hip fracture surgeries. So first of all, how long we will give the prophylaxis? That is for 35 days. Now which agent we will use for prophylaxis? Here the drug which should be used is a low molecular weight heparin. So it can be either Clexane, that is enoxaparin, or it can be a deltaparin. So these are the drugs that we use, and these drugs should be used for 35 days. If the patient is having a kidney failure with a creatinine clearance of less than 30 ml per minute, then unfractionated heparin should be used. Or if we want to use an oral drug, then we can prefer warfarin. We will discuss about the dosage subsequently. And when should we start it after the surgery? More than 12 hours after surgery. So this is about the hip fracture. Similarly, let's talk about the hip replacement. Again, we should use it for 35 days. Now here the agent that we use is a low molecular weight heparin or DOAC, directly acting or direct oral anticoagulant. So these are oral anticoagulant directly acting. So the commonly used are either we can use rivaroxaban or we can use apixaban. So both are equally good. So we can use any of the two drugs, either rivaroxaban or apixaban. So these are the preferred agents in hip replacement as compared to the low molecular weight heparin. So if the patient is a low risk patient means that the patient is we are giving prophylaxis only for this surgical condition, there is no other condition, and patient is a young patient, and like we are doing only unilateral replacement. So if these are the situation, patient is a low risk for developing venous thromboembolism, then total of 35 days we have to use, but we can split this 35 days into 5 to 10 days of DOAC, that means either rivaroxaban or apixaban. Then after that we can give aspirin, that is 75 mg OD for another till we complete 35 days. Like we have given for 5 days, then we give it for 30 days. We gave it for DOAC, we give for 10 days, then we give aspirin for 25 days. So total of 35 days. Similarly, if the patient is having kidney failure, then we will use unfractionated heparin or warfarin. Again, we will start this after 12 hours of surgery. We will not start it before 12 hours of surgery, otherwise it may increase our bleeding diathesis, or drain may have higher amount of the blood. Similarly, we talk about the knee replacement surgery. Here we give it only for 14 days, not for 35 days. So again, the agent is either low molecular weight heparin like enoxaparin, or directly oral anticoagulant like apixaban or rivaroxaban. So any of the two drugs. So when again similarly we can give it for 5 days of rivaroxaban or apixaban, then rest of the 9 days we can give aspirin in low risk patient. If the patient is a high risk, then we have to give the same agent for the 14 days, either low molecular weight heparin or DOAC. So again, if the patient is having kidney failure, then we cannot give it. We will give unfractionated heparin, and we will again start it more than 12 hours after the surgery. So Let's talk about if these were the patients with a major orthopedic injury. Now, if the patient is not having a major orthopedic injury and this is a non-major orthopedic injury, like we are doing closed reduction or open reduction of a long fracture including the femur or the tibia, here the femur is excluded around the peritrochanteric fractures, and or the patient is having a soft tissue injury like quadriceps rupture or arthroscopy of the knee and the hip, foot and ankle, shoulder, elbow, wrist surgeries, then how should we give it? So here we can give low molecular weight heparin till immobilization period. Like if the patient is mobilized from the next day, we can give it till the next day. So let's understand this again. Like after the surgery, then we will look for any contraindication. If there is any contraindication to the venous thromboembolism prophylaxis, like the patient is having a very low platelet count, like less than 50,000, there is a active bleed somewhere which is clinically not acceptable, and or if there is an intracranial hemorrhage in the patient, so in those patients we will not use the venous thromboembolism, but in those patients we will use only the mechanical thromboembolic agents. Now, if there is no contraindication to these drugs and the creatinine clearance is less than 30 minutes, then we will use only unfractionated heparin. If the creatinine clearance is okay, then we will look at the type of the surgery. If it is a hip replacement or knee replacement, then we can give either unfractionated heparin or prefer rivaroxaban or apixaban directly or direct oral anticoagulant therapy. In the hip fracture, we may prefer low molecular weight heparin. So this was about these drugs. Now let's look at the doses. So the low molecular weight heparin we will start 12 hours after the surgery, and the two drugs are preferred. Either we can prefer enoxaparin or deltaparin. Enoxaparin we can give 30 mg BD or just 40 mg once a day. Deltaparin we can give 5000 milligram subcutaneous once a day. So these are the two drugs which we prefer. Then similarly, direct oral anticoagulant, the two drugs again we prefer because these drugs have the safety data availability and efficacy data availability. So rivaroxaban or apixaban. If we want to give rivaroxaban, we give 10 mg once a day, and we start this more than 10 hours after the surgery. And apixaban we can start 2.5 mg twice a day. So many people give once a day, but the recommendation is we should give it twice a day, and it should be given more than 12 hours after surgery. So this is about this. Then ASA means the aspirin. This is the dose is 75 mg once a day. Unfractionated heparin is 5000 units subcutaneous twice daily, and warfarin is 5 mg orally once a day. It should be started more than 24 hours after the surgery, and then dose is adjusted to target INR. We usually target the INR between 2 to 3, like 2.5 for example. So this is how we adjust the dose of the warfarin. So now what should be the duration of the treatment? Like we have already seen in hip and knee replacement surgery, the patient is a low risk. Low risk means there is a no risk, other risk for venous thromboembolism, no other indication for long-term therapy. There is no lower limb or fracture within last 3 months of the surgery, and the procedure is elective and only unilateral surgery is done. Patient is ambulated less than 24 hours of the surgery. If this is the situation, then we can give 5 to 10 days of the either low molecular weight heparin or direct oral anticoagulants, followed by the aspirin for rest of the time. Like in knee, it is a total of the 14 days, and hip it is total of the 35 days. So if the patient is not a low risk, patient is a high risk, then we will not shift the patient to aspirin. Then in total hip replacement patients, we will use the direct oral anticoagulants, yani ke enoxaparin, apixaban or rivaroxaban for total of 35 days, and in knee replacement, we will continue it for 14 to 15 days and rivaroxaban or apixaban. So then we will not shift to the aspirin. So aspirin used only for the low risk patients. Then the duration of treatment in hip fracture is 35 days, and the preferred agent is not DOAC, it is low molecular weight heparin. We can give direct oral anticoagulants, but preferred is a low molecular weight heparin. So this was about the venous thromboembolism post knee hip replacement or hip fracture surgeries or non-major orthopedic surgeries. So thank you guys, thank you very much. For more such video, please like, share and subscribe to our channel. Thank you very much.